Today, from Society of Genitourinary Oncology, SOGO, we have the Penile Cancer Masterclass. Most of the topics will be nicely covered. And to begin this program, I invite Dr. Sudhir Rawal, Director, Rajiv Gandhi Cancer Institute, Uro-oncologist and President-elect SOGO, to welcome everybody. Sir.
Thank you, Ganesh, and it is my pleasure to welcome you all for this first masterclass, which is being organized by SOGO. As you know, that this is a society which is just focusing on urological cancer in all aspects, in medical, radiation, in surgical, molecular, and other aspects, pathology, and everything. And this is our effort to teach our urologists, uro-oncologists in our country, maybe outside also. And this is after this master class, there will be regular master classes, which will be announced at the end by Dr. Raghunath. And the next master class he will announce. So this is going to help everyone, and it will be a great learning. You can ask your friends to join these classes, as they will be just focusing on uro-oncology, all the aspects. With that, I welcome you all for first master class, which is will be moderated by Ganesh, Vedang, and other big name in uro-oncology. Ganesh, please.
Thank you so much, sir, for giving the introduction to this penile cancer masterclass. And I invite Dr. Vedang Murthy, who will be the session moderator for this session. He is also the program director. Vedang, please come in.
Thanks, Ganesh. Let's get on with the masterclass. The first session is about the treatment of the primary in penile cancer, and let me invite Dr. Raghavan, a senior uro-oncologist from Apollo Chennai, to talk about pre-neoplastic lesions and how to differentiate them from cancer. Raghavan.
My most sincere thanks to the organizers, especially the program directors Ganesh, Bakshi, and Vedang. And my most sincere thanks to Professor Kulkarni and Professor Raval. So I'm going to talk quickly about pre-malignant lesions in the penile penis. So it is especially important for postgraduates. I'm hoping that all the postgraduates are listening to this talk. There are 7 conditions that one has to be careful when it comes to cancer predisposition in penis. Cutaneous horn. Cutaneous horn is a rare lesion. You will see a very hard nodule in the glans or in the shaft, and it usually comes in a pre-existing wart or a traumatic abrasion or anything like that. Associated with HPV-16 virus, surgical excision with a good margin is what is required, and recurrence can happen. Will this itself become a malignant lesion? Very rare, but HPV-16 is associated with malignancy. So keep in mind that it is the same organ which is predisposed for both. Next is pseudoepitheliomatous, mycaceous, and keratosis balanitis. A very long name. Primarily, that is fungal keratitis, hyperkeratotic lesions. Just see the pictures. It will be very useful if you remember these pictures. Microscopic features will be suggested something like a verrucous carcinoma. It tends to recur. You can do excision, laser, or if the whole glans is involved, you can even do a glanzectomy as well. Balanitis xerotica obliterans. That is the most commonest thing that you and me come across in our practice. It's a whitish preputial patch. Very, very common. It's a mosaic appearance. Usually the meatus gets involved. Repeated meatal stenosis happens. For exam purposes, histology will be atrophic dermatitis with loss of retive pegs and homogenization of the collagen. It is a very classical histological description. So keep this in your mind for your exams as well. The treatment is inevitably circumcision, and please have a close follow-up. In some series, it is reported that 1% of BXO will have malignancy. So please have these patients on an annual follow-up. Leukoplakia Its presence as a solitary or multiple whitish plaques involves a meatus. It is a very important thing. These are the things you need the help of a dermatologist who do a very thin dissection and take it for the histology. The dermatologist helps me in doing that histological, otherwise we will end up doing a wedge excision. It's very important to look into it to check for the malignant change, and if there is a malignant change, it has to be treated that way. Try to eliminate the chronic irritation things, including consider a circumcision as well. Previously, radiation has been used, but that is not the standard of care to my knowledge now. Carcinoma in situ will be associated with this patient, so hence be careful with them. Very close follow-up is required. I tend to ask these patients to come every 6 months to the OPD for a review. Now, condylomata acuminata or genital warts. Now, this itself is not malignant, but keep in mind this is associated with HPV infection, which in turn is predisposes one for malignancy. A proper excision and then subsequently treatment with podophyllin is important. If you don't do a circumcision and use podophyllin, there will be so much of necrosis of the foreskin, and therefore it will be very cumbersome. Hence, go for a circumcision, prefer a radical circumcision, and then subsequently use podophyllin for these patients. A surgical laser can also be used. You need to work in association with your dermatologist for this. And keep in mind, these patients need a very strict follow-up. Verrucous carcinoma, or also called as Buschke-Levinstein tumor, it's a massive tumor that involves the genital area, looks very ghastly, but rarely, if not almost impossibly, doesn't metastasize to the lymph nodes at all. If the patient has a concomitant lymph node metastasis, keep in mind there is an underlying invasive cancer rather than Buschke-Levinstein. The most common cause of enlargement of lymph nodes in these patients are related to infection rather than metastasis. Erythroplasia of Poirot and Bowen's disease are two diseases which are primarily the same thing. It's red velvety lesion which causes a bit of an ulceration involving the glands in erythroplasia of Poirot, and Bowen's disease involves the shaft. 100% histological confirmation is required, radical circumcision, if necessary laser fulguration, and on top of that topical 5FU treatment is required. Thank you. I have not touched upon carcinoma in situ, which I presume will be touched upon by the later speakers. Carcinoma in situ is cancer itself, and patients are commonly diagnosed because they have velvety plaque, very similar to erythroplasia of Poirot, and those patients will require long-term 5FU treatment, 6 months to 1 year. Thank you so much.
Thank you so much, Raghavan. It was a perfect start, on time, and beautifully taught to, especially for the postgraduates. We'll move on to the next talk, another very interesting one by Dr. Anand Raja from Cancer Institute, Adyar. He'll talk about how imaging has implications on management of penile cancers. Anand, please.
Am I audible? Sorry.
Yes, Anand. Please put it on the screen.
Yeah. 1 second. Yeah. So, greetings from the Adyar Cancer Institute in Chennai. I'll be speaking today on imaging on penile cancer and implications in management. So, when we talk about imaging, there are primarily three things that we talk about. There is imaging of the primary, there is the imaging of the metastatic lymphadenopathy, and there's imaging of distant metastasis. We will not be talking about in great detail about the distant metastasis. I'll just mention it. What we'll primarily be talking about is how to image the primary, how to image the nodes, and what are its implications, how and what do we do. So imaging of the primary tumor, the primary tumor is staged by palpation and can often result in understaging of the disease. So you need to image it. It is important for both prognostication as well as for treatment planning. The modality of choice is MRI. It can be clinical evaluation can be very complacent. It can enhance the accuracy of preoperative staging. MR imaging depicts the penile anatomy in detail, including its relationship to various structures, and helps to identify invasion of the cavernosa, the spongiosa, the urethra, the prostate, the scrotum, and the abdominal wall and adjacent organs. So just to limit here, just these are the last words that you will see here. Everything else is going to be photographs. Just remember here, just these four things, if you remember, that's more than enough. You have to know what is normal first before you know what is abnormal. The cavernosa and the spongiosa have intermediate signal intensity on the T1 weighted MRI sequences and high signal intensity on the T2 weighted sequences. The MR cannot reliably distinguish between the albuginea and the Buck's fascia and are depicted as a uniformly single thick rim that is hypointense. The contrast between the corpora and the tunica albuginea increases on T2 imaging, and the dartos fascia appears hypointense on all sequences. So this is basically the transverse section of what an actual axial section of the penis looks like. The second image on the left shows what is relevant for imaging, and then the middle picture here in black, that is what you'll usually see. The outermost layer, as you see, will be the skin and the dartos, which are hypointense. The Buck's fascia and the tunica albuginea are uniformly bright, or uniformly dark, can't distinguish between the two, and in between these two lie the cavernosa and the spongiosa. So again, this is part of the normal anatomy. The middle picture you can see, you can basically see the ischiocavernosus going on to the pelvis. The image on the left, you can see the spongiosa going on to the bulbar urethra, and the one on the right, you can see all the three together. The spongiosa and cavernosa enhance with administration of conjas, with the spongiosa occurring faster. Only two things you need to remember. If you have to just look at one MR protocol, you need to look at only two images. You need to look at the T2 weighted images in all the three planes, axial, coronal, and sagittal. And the post contrast T1 is what is important. So the T2 and the post contrast T1 with fat suppressed, those are the only two important images that you need to look at. So just coming back here, again, I think I have better pictures here. So you can see here the image on the top left, you can see a diffusely heterointense lesion invading along the entire urethra. I'll come to the significance later on. The one on the right, the two on the right, as you can see very well, the one on the right is basically a recurrence that's happening at the base of the penis, and it's invading the levators, as you can see. On contrast, the whole thing brights up, and the invasion is seen much better. Again, very important here, the two images, all these belong to the same patient. The invasion of the scrotum can be seen on the image on the left, which is T1. But on the contrast administration, as you can see the infiltration of the skin is seen so much better. The invasion of the scrotal skin is seen so much better. The image in the middle, as you can very easily see, this is a T2 image. As you see, the lesion is there, and you can very subtly see that it's going on towards the scrotum, it's invading into the scrotum, and when you give contrast on the one on the right side, that enhancement is seen really well. Again, all these images belong to the same patient. Again, this is a patient for a recurrence. As you can see, this patient is recurred. You need to do the sagittal and coronal images. You can see the depth of infiltration. You can see how long into the urethra and into the prostate the tumor is extended. It can along the entire urethra into the prostate, sometimes even into the bladder. And again, as you can see here, the skin infiltration can be missed in the SAGS T2 images. But when you give the contrast on the T1, the image in between the arrow marked with white, you can subtly see that the skin infiltration is there. So you need to give margins to the skin infiltration and not to the one that is seen only on the T2. So you need to look at these two images, see what is the extent of disease, and then take a call further what needs to be done. Imaging for metastatic lymphadenopathy, again, clinical methods are unreliable for detecting metastasis. As we all know, most 50% can be palpable, 50% can be impalpable. The modalities are USG, CT, MRI not so commonly used. The ultrasound groin is usually used. You need to see the size, you need to see the shape. The short to long axis ratio more than 0.5 is suggestive of malignancy. You need to look at borders. Unlike what people think, malignancy will have sharp borders as compared to inflammatory conditions which will have blurred borders. You need to see the echogenicity. You need to see whether the hilum, the echogenicity is lost or not. You need to see intranodal necrosis, which is again suggestive of malignancy, as you can see in the slide on the right side, the image on the right side, and calcification within the nodes. Again, just important to remember here, these are squamous cell carcinomas which can have necrosis and calcification. CT scans, again, contrast CT scan is mandatory. You can see here a tumor which is invading the entire corpora. You can see all these metastatic nodes which have extensive necrosis, and the periphery is enhancing on contrast. Again, why do we need to do these CT scans? You can see all these conventional CT scans. You can see nodes. If the nodes are enhancing, they are more suggestive of malignancy. You can also see the fat plane. If the fat plane is lost, as you can see the image on the right side, on the left side, the image on top, the fat plane is lost with the vessel. This probably tells us that the vein is probably infiltrated. Again, similarly, not only can you see vascular infiltration, you can also see that the pectineus and the floor of the adductor canal is infiltrated by tumor. And you can have these large necrotic nodes. It's very important in FNAC, because if you're going to do FNAC, so the necrotic component, I mean, if you do a bad FNAC, you're only going to get a bad result. Sometimes imaging is necessary so that you can target the solid areas. Again, that's not only for the inguinal region, you can also see it for the iliac regions. We see all these big nodes somewhere that you can see in the iliac region. Probably best not to go and operate on these patients. And again, you can see whether they are invading onto the external iliac nodes, whether there is any loss of fat plane or not, whether this may be after chemotherapy also, whether it's really worth resecting or not. Again, just imaging to say that there can be not only these big nodes, but there can be these nodes that are flat and applied to the vessel wall very closely. Again, loss of fat plane between the node and the external iliac veins. And not only inguinal iliac, but again, very important is to look at retroperitoneal lymphadenopathy. Again, a large enlarged precable node. This patient is beyond the purview of cure at any point in time. There's a small role for doing a Doppler. It can act as an adjunct. Very rarely, sometimes you can see a thrombus or something like that into the vein. Sometimes it will show you whether the vein is flowing or not, whether the vein wall is invaded or not. That can be known. As far as the metastatic workup is concerned, the standard investigation is a CT scan abdomen pelvis, and the CT chest is what is recommended for metastatic workup. A PET CT scans can be done, can add value, but there's really no recommendations to do these. They neither help stage the patient locally nor distally until and unless there is some indeterminate lesions that you want to know. Thank you so much. And with this, I end my talk. And I deeply acknowledge the Department of Radiodiagnosis for providing me with all these images and for doing a fabulous job here at the Institute. Thank you so much.
Thank you so much, Anand. We don't have any questions in the chat box, so I'll straight away invite the speaker for the next talk, Dr. Umesh Mahanchetty, my friend and former colleague, who is the director of HPCH Vizag, and he'll talk about radiotherapy for primary penile cancers.
Yeah. So am I audible, Veda?
Yeah, all set.
Yeah, okay. Thank you. So at the outset, I would like to thank Sogo for inviting me, and in particular Ganesh and Vedang. And I've been working with them for almost 2 decades now. What I will do is the mandate given to me is to highlight the role of radiation therapy for penile preserving strategies. And what I will do is I will give a brief overview of what is possible and what can be done for these patients. To have a quick background, the incidence of penile cancer is very, very low. Equally important is mortality is also relatively low. For example, the incidence is 1.1 to 1.5 per 100,000, and the mortality is ranging between 20 to 40%. And this is essentially because penile cancers are primarily a locoregional disease and very rare metastatic at presentation. As you all know, evaluation and staging is very important. This is not only to define the treatment, but also for prognostication of the treatment. Suffice to say that early T stage presentation is very common, And in recent past, there have been a lot of stratification which have been recommended by EAU, which is followed in routine clinical practice. When it comes to the treatments for locoregional disease, surgery has been historically the treatment of choice for primary disease. However, it is associated with physical dysfunction, psychological dysfunction, and sexual dysfunction, although it gives an effective control. What I'm going to talk in detail is about the radiotherapy, and the primary advantages of radiotherapy for primary disease are that we tend to offer an organ preservation without compromising local control and survivals. It also, to a large extent, retains erectile potency and sexual function. It eliminates psychological distress. And the commonest indication for radiotherapy are young age group, T1 to T3 select patients. When I say select, it is, let's say, for example, in this picture, lesions which are confined to glands and appear to involve, let's say, the distal 1 or 2 centimeters of the urethra, where still penile conservative therapy in the form of radiation can be given. Tumor size less than 4 centimeters. And most important is patient's desire for organ and function preservation is very important indication for giving radiotherapy. So what are the options if we have to offer radiotherapy? We have options of external beam radiation, where we complete the entire treatment in 3 to 4 weeks in an accelerated fashion, or give a conventional radiation of 6 weeks with 60 gray in 30 fractions. The other alternative is brachytherapy, and in brachytherapy we have 2 types of treatment. One is the interstitial, putting the tubes and needles. I will show you some pictures, or a surface mold for very early superficial lesions. And in terms of brachytherapy doses, which are defined by the dose rate, low dose rate or high dose rate brachytherapy has been utilized for treating with brachytherapy. Just to give a flavor of an example, this is a prospective study from Tata Hospital, 23 patients of stage 1, stage 2 treated with radical radiation therapy in the form of external beam. Stage 1 were 17 and stage 2 16. This is very important slide in which we have shown a picture where typically a patient with penile cancer being radiated with external beam radiation therapy, and this is a box made up of a perspex sheet or a plastic sheet, and in this box is filled with the box is filled with water. In the center there is a hollow opening through which the penis is pulled up with the help of cellophane which is wrapped around the penis, and by doing this and putting some lead sheets below to spare the doses going to the testis, radiation is delivered with the help of either cobalt machine or linear accelerators. In this study, what we found was in stage 1, more or less, we achieved 92% penile preservation rates, and after offering salvage therapy, 100% of the patients had penile the control rates. Whereas in stage 2, the penile control rates were very less as compared to literature, but still all were able to salvage with salvage surgery. Most important is we also evaluated the sexual functions. In blue is shown as the pre-radiotherapy sexual function, and you can appreciate that this is more or less a normal male having various functions. Whereas in the green is what patients have achieved after completion of radiotherapy, and you can see very clearly that more than 85% of the patients do have retained all these sexual functions, which are very vital for young patients who have these early cancers. So the conclusion of this study was that this is an effective alternative to surgery in terms of local control, but added advantage is the penile conservation, so that the organ and function preservation is maintained, and surgery has to be kept as salvage. The second treatment modality is brachytherapy, and in this I have shown pictures from various literatures which are published. The top panel shows the typical brachytherapy procedure which was done with low dose rate brachytherapy, and in the lower panel is the high dose rate brachytherapy, which includes either interstitial or use of these plates to push the needles across the lesion. And the last non-invasive technique is the surface mold, where the penis is treated with this surface mold which is placed on the lesion, and this is typically done for superficial tumors. This is the data from Tata Memorial Center, which has been published by Dr. Ashok Chaudhary. I'm sure Dr. Dr. Pulkare will remember this. They published literature of roughly around 23 patients, and you can see control rates of almost 80% with penile preservation rates of 70 to 80%. And this is a busy table, but I wouldn't go into details. But what I've highlighted is to show that penile preservation rates can range from 60 to 90% based on the case selection, and after salvage, the local controls can be as high as 96% without major toxicities. The only toxicity which happens with radiotherapy is the urethral stenosis in the distal urethra, which can be easily managed by the urologist or subsequently by patient himself. Subsequently, in the last few years, high dose rate brachytherapy is becoming more popular, and this is a workflow of one of the patients which I did while I was working in Tata Hospital, and we have roughly around 25-30 patients, and I believe Vedang is trying to analyze these patients for the disease outcome. Having said that, brachytherapy definitely is skill-oriented, and it has to be carefully executed by a person who is trained in brachytherapy. But nevertheless, the advantage of doing brachytherapy is shown in this picture. Urethra can be spared of the high doses, and at the same time, the high dose region can be confined to the target or the tumor. By doing that, the urethral toxicity can be reduced further. This is an example of experience from AIIMS, Delhi, where 14 patients were reported, and they did report a penile preservation rate of 93% with no urethral stenosis shown in this series. And what you see is 10 patients out of 14 had satisfactory sexual function. And the recent literature also shows the same, that the local control and penile preservation rates are as high as almost 100% with high dose rate brachytherapy. So in summary, for early penile cancers, T1 and T3 select tumors, I think radiotherapy is an effective organ and function preservation modality which should be offered to patients who are relatively young. And if we have to offer radiotherapy, external radiation is widely available now, and the treatment is simple and easy to implement. Whereas if we are offering brachytherapy, then it has to be referred to a center who is experienced in doing brachytherapy across various sites. And commonly, high dose rate brachytherapy is utilized. For superficial tumors, we usually tend to do surface mold using a wax or duodenum dressing. Whereas for invasive tumors, we tend to do interstitial high dose rate brachytherapy. But what is most important take-home message from my talk is that it is always good to have a multidisciplinary team approach and discuss the patient in the presence of a surgeon, radiation oncologist, pathologist, and a radiologist, and give the optimum option to the patient based on the tumor. I thank you for your kind attention, and I would like to acknowledge the Urology Disease Management Group of TMC, Vedang and his team at TMC, and last but not the least, patients. Thank you.
Thank you so much, Umesh. Excellent as usual. Two quick questions and quick answers, please. So we talk about advanced technology in radiotherapy for almost every talk. There's a question, are there any advances in radiotherapy to preserve erectile and mainly stricture after radiotherapy in penile cancer? Is it a valid thing, advances in advanced radiotherapy?
Well, I agree that there are advances in radiation therapy technology today, but when you have simpler techniques, should keep it simple as possible, so that stick to the basics.
So another very specific question is about surface mold. Would you recommend a certain depth of invasion for indication of surface mold?
Usually surface molds, we try to keep it less than 3 millimeters of infiltration. So that's why I mentioned that superficial tumors are usually treated with surface mold. Having said that, I'm always comfortable doing interstitial because you always know that your margins of treatment are better, so that it doesn't matter if you're doing brachytherapy and you over-treat few millimeters for better penile preservation rates.
Okay. And would you follow up the patients only clinically, or would you do any imaging after that?
Well, depending on the type of lesion, T1 usually clinical is good enough, but T2, if they are borderline, then maybe clinical examination to find out inguinal nodes, or ultrasound on regular basis should be good enough for these patients. But when you have a recurrence, then definitely evaluation has to be done.
No particular imaging for the primary is required.
Not required.
Okay, thank you so much, Umesh. Great job.
Thank you, Vedant.
Next, I'd like to invite Dr. Srivatsa, uro-oncologist from Bangalore, to talk about the surgical options for preserving the penile function and anatomy. Srivatsa. We can't hear you, Srivatsa. You'll have to unmute. Can the admin unmute him, please?
Sir, am I audible now?
Yes, yes.
I'm sorry, I don't know what happened. Is my screen visible?
Yes, yes, everything is fine. Please start.
Yeah. So we all know that more than 55 to 60% of patients are relatively young who prefer to have better quality of life in terms of urinary function as well as
sexual. Can you put it on slideshow, please? Yeah.
Yeah. So, and preservation will also considerably offer a psychological advantage of potentially mutilating surgery, and therefore there is a need for organ preservation. The indications are favorable histological features of stages carcinoma in situ, PAT1, of low grade and moderate grade variety, as well as carefully selected T2 lesions, preferably involving only the glands and typically less than 4 centimeters in size. So are my slides moving?
Yes, yes.
Yes, yes.
I'm not able to, I'm really sorry, I don't know what's happening.
You are at the indication slide right now.
Now, is it moving?
No, no. You click on the presentation first and then move it.
Yeah. So coming to the outcomes-based rationale, the goal of organ preservation is to preserve gland sensation where possible, or at least maximize penile shaft length without compromising the oncological control. And this has been given a lot of support with the recent data coming in the last 2 decades, where the historical 2 centimeter margin has been challenged with several studies which have now shown that limited margins are as good and as efficient in providing equivalent oncological outcomes, and therefore gives us a impetus to do organ preservation. Second point is that 83% of recurrences, when they happen, are typically local with very low risk of inguinal nodal metastasis, which makes it amenable for an attempt at recure. And it has now been proven in several studies that local recurrence has little influence on long-term survival, and therefore organ preservation strategies are justified. So there are several non-surgical and surgical options to offer organ preservation, like the topical chemotherapy, radiotherapy, which has already been alluded to, cryosurgery, chemotherapy, and immunotherapy. And in the surgical arm, we have the laser ablation alone or in combination with limited surgery or radiotherapy, Mohs micrographic surgery, and various conservative surgeries like the glands preserving partial glandsectomy alone, or glands resurfacing, or penile disassembly. Coming to topical therapy, it is useful only in situ malignancies. Imiquimod or 5-fluorouracil have been historically used. 5-fluorouracil is easier to use and to retain on the tumor surface, and therefore is the treatment of choice. It is preferable to do a circumcision prior to use of topical agents. Unfortunately, it has high persistence rates and recurrence rates. Response rate again must be always assessed by a rebiopsy, and a long-term surveillance is warranted. Insufficient response typically signifies more than carcinoma in situ disease, and complete responses have been seen in up to 57% of PIN cases and 74% of cases treated by circumcision along with 5-fluorouracil without any long-term relapse. And if treatment fails, there is no option for reuse of the same therapy. A different therapy should be applied. Coming to laser ablation, several lasers have been used. Carbon dioxide is widely available, but unfortunately has a very limited depth of penetration, only 0.1 mm. It produces considerable amount of charring, making it difficult to assess residual tumor on rebiopsy. Local recurrence rates are very high, close to 50%, and therefore it is considered less than optimal for treatment of penile tumors. Nd:YAG laser is the most commonly used. It has a good depth of penetration up to 6 mm, and therefore can be used for TIS as well as T1 lesions. The challenges with Nd:YAG is that it produces extensive coagulative necrosis, making interpretation on frozen very difficult. The overall recurrence rates are typically comparable to that of partial penectomy in carefully selected patients. One of the strategies used along with Nd:YAG is to use 5-aminolevulinic acid induced fluorescence for targeting the frozen section biopsy specimen, so that the margin rates are better with Nd:YAG excision. This is another combination, laser treatment in association with radiotherapy or chemotherapy for in situ or T1 penile cancers. There have been a study which has shown that there have been no cancer-specific deaths. The cumulative risk as well as the rate of inguinal nodal recurrence is equivalent or comparable to partial penectomy, and the rate of secondary partial penectomy at 10 years is very low, 3% for in situ cancers and 10% for T1 tumors. This is one of the images from our own repository, where you can see extensive charring in the first image after the laser excision followed by interstitial brachytherapy and at 6 months of follow-up. The advantages of laser therapy are a good number of patients resume normal sexual activity, and a vast majority of patients are satisfied with this treatment. Coming to limited excision strategies, there is circumcision, a limited excision of glands removal with sparing of penile shaft, that is glansectomy, glans resurfacing, and penile disassembly. Whenever these strategies are carefully applied, it has been now proven that the oncological outcomes long term, that is up to 10 years, is equivalent to that of partial penectomy. So this is an image showing melanoma, small melanoma in the coronal, just proximal to the coronal circus, where wide excision was achieved, preserving the entire length of the phallus intact. And this is a case of partial glansectomy, and we have used the penile skin to advance and then retain the phallic length. And coming to gland stripping, which is again most commonly used, it is typically used in verrucous cancers, where subdermal dissection of the skin and subepithelial connective tissue of the underlying corpora spongiosa is achieved, and it consists of complete removal of glandular epithelium followed by reconstruction with a graft, typically from split skin or from the buccal mucosa. Again, in carefully selected patients, the local recurrence rates are very low. This is an image showing a verrucous carcinoma which was treated with glans resurfacing. What I would like to highlight here is that frozen section assessment of the negative margin is absolutely mandatory before undertaking any of these procedures. Mohs micrographic surgery, proposed in 1942 for basal cell carcinoma, applied for penile cancers, has not unfortunately given the same kind of results compared to the fixed tissue technique, along with, in comparison to the frozen section, and therefore probably not being as widely adopted as in the past. Penile disassembly is an interesting concept. We have not done any. This is published by Francisco Martins and his colleagues, where they completely, here in this image you can see that there is a glandular tumor, which and they do a circumferential incision, completely dismember all components of the penis, excise the tumor, and finally reconstruct the penis. The entire length of the phallus is maintained, good cosmesis is achieved, and good functionality is achieved. So coming to the conclusion of penile preserving treatments for carcinoma in situ, we can consider laser therapy, gland resurfacing, or alternatively in carefully selected patients, topical therapy. For TA and carcinoma in situ patients, surgical excision is also a very good alternative to laser therapy as well as topical therapy. For high-grade T1 lesions, the therapy is based on the position of the and the size of the lesion as well as the potential side effects, and it can include either excision, gland resurfacing procedure, glandsectomy, or radiotherapy. For T1 high-grade lesions, even complete surgical excision of all modalities, wherever penile the length is possible to be preserved, is good. And in select T2 patients, again, total glandsectomy with or without corporocavernosa transection to achieve negative surgical margins, or a radiotherapy can be employed. To conclude, radical treatment is not always necessary and has now been proven that partial penectomy remains the current gold standard, but novel approaches are probably as equally effective, especially when stage-based decision on management has been made. Penile preservation, however, should not compromise oncological outcomes, and therefore joint discussion with all the stakeholders, the radiation oncologist, the pathologist, is absolutely mandatory. Carefully selected patients and well-done treatments can achieve equivalent oncological outcomes as the gold standard. Intraoperative ascertainment of negative margins is a must, and again, long-term surveillance is mandatory, including a low threshold for rebiopsy. Thank you very much.
Thank you very much, Shweta. That was very well covered. There are no questions in the chat box. If there are some, we can probably take them up in the panel. So with that, I'd like to hand over to my colleague, Dr. Bhakti, to start the next session.
I think the next session, first talk, Sanjay is already there. Management of CN0 groins, clinically node-negative patients in penile cancer. Dr. Sanjay is Senior Consultant Surgical Uroncologist, Apollo Cancer Institute, Jubilee Hills, Hyderabad. Please.
Thank you very much. Thanks for this opportunity. It allowed me to read up on what is latest, and I'm grateful to Rakesh for giving me some of the slides. So, what are clinically end-node groins? First, as Dr. Ganesh has mentioned, no palpable or enlarged inguinal lymph nodes, no suspicious lymph nodes on ultrasound scan. Then the third one, which I found it surprising, but palpably enlarged, but the FNAC is negative, is also categorized as an end-node groin. What is the incidence of it? It's variable in India depending on where you work. This is what we can notice, up to 90% of the patient having clinically palpable. So CN0 is probably as not common in India as in Western societies, because we tend to pick them up a bit late. What are the options? Clinical surveillance, which is with clinical examination, radiological surveillance, DSNB, and modified inguinal lymph node biopsy. These are the 4 options. The reason why there are options is, in a patient who is clinically node negative, up to 25% of the patients tend to have metastatic disease. So in a way, you can say, okay, why don't we just wait until those 25% of the patients show up and do a lymph node dissection, i.e., why overtreat 75% of the patients to treat those 25% of the patients? So can we just keep every patient who does not have clinically palpable lymph nodes on surveillance? The reason why we need to have some sort of a management pathway for these patients is twofold. One is, you can see that for a patient who has got CN0, the survival at 5 years seems to be around 90% compared to survival of around 40% for clinically N1 to N3. Whereas when you look at pathological, again the same. So a patient who is clinically N0 but pathologically N1 does need to know that they have got very high probability of death from penile cancer. So that's the reason we need to know. Then the second one is, this is from the Brazilian Institute, Cancer Institute. If you see the patients who underwent immediate ILND and ILND at recurrence, ILND at recurrence, the survival, the 10-year cancer-specific survival is 40%. So we cannot wait for these patients to present with metastasis and treat, because the survival is impacted. And when you look at where does the recurrence happen and what is the impact on the survival, you look at this one, when the local recurrence is there, it doesn't seem to have that much of a difference. You can go back and operate and still there isn't any impact on the cancer specific survival. Whereas whenever there is a lymph node recurrence, they do tend to have quite a bad outcomes. So that is the reason why we cannot keep these patients on surveillance. But can we keep any patients on surveillance? These are the EAU guidelines. So low grade T1, low grade TA, and TIS. Those are the ones that we can keep. But I'm a bit uncomfortable about keeping even this T1, G1, T1. The reason is when you look at the TNM staging, there is a T1A and T1B. EAU guidelines don't tend to differentiate. If you look at the TNM 2016 staging, there is one without LV invasion and one with LV invasion. And when you look at the NCCN guidelines, it tends to differentiate it better. The low risk ones are the TIS, TA, T1A for surveillance, whereas the others, which are the intermediate and high risk, clinically N0 lymph nodes, there are only two options. One is ILND or dynamic sentinel lymph node biopsy. You got modified ILND or dynamic sentinel lymph node biopsy. So those are the only two options according to the NCCN, which I think is a bit more precise compared to what the EAU guidelines have mentioned. The reason for that is, if you look at the low grade one, the chance of positive lymph nodes is small. The moment you go up to G2, T1, then it does tend to. So we know that both the stage and the grade do have an influence with respect to the chances of having lymph node metastasis. So I have gone through who are the patients who can be on clinical surveillance. What about radiological surveillance? We always tend to request for ultrasound scan of the groins. The straightforward answer is none of these are of any use in CN0. CN0, clinically, if you can't feel, you can't see them on any of the imaging. When you can feel, that is clinically N1, then you can try to characterize them, whether they have got central, the shape of them, central echogenicity, where is the perfusion, then you can see. But as you can see, the sensitivity of an ultrasound scan is only 40%. So you will miss 60% of pathological lymph nodes if they don't come by the size criteria. Same with respect to either the CT scan or MRI scan. I need to be specific in mentioning this. I'm only mentioning about usage of ultrasound scan, CT scan or MRI scan in CN0, not in palpable lymph nodes. Again, if you can't feel them, you can't see them. Minimum size criteria is 8 millimeters. 8 millimeters, especially in somebody who's not fat, you should be able to feel it. How about PET CT scan, the latest tool? Again, when you look at the overall PET CT scan pooled sensitivity analysis, it seems to be around 80%. But when you look at CN0, the sensitivity is only 56%. So you end up losing almost 45% of the patients if you were using PET CT scan to determine what to do for the CN0 patients. Same with the CT scan or ultrasound guided FNAC, sensitivity is variable between 34 to 100, false negative rate of up to 30%. So in essence, radiological surveillance, i.e. using radiology to determine whether you want to do groin node dissection or not in a CN0, the straightforward answer is no role, because you will miss around 30 to 40% of occult metastasis. Dynamic sentinel lymph node biopsy and modified inguinal, those are the only two options whenever the patient is either intermediate or high risk. The technique involves injecting the radiocolloid the day before, blue dye on the day of the surgery, and using a perioperative ultrasound scan so that anything that is visible while you are doing the sentinel lymph node, you can do an FNAC of them. So those are the three modalities that need to be done. And what it shows is even that one is not foolproof. You tend to miss around 7 to 8% of this. This is a false negative rate, seems to be around 7 to 8%. And these are quite good numbers. When 400, 150, so quite good numbers. So sentinel lymph node biopsy has got a false negative rate of around 7 to 8%. How about adding another layer, which is the blue dye, fluorescence, as well as the gamma probe? And if you can see here, what this indicates is just using the blue dye for sentinel lymph node is inadequate. That's what it is showing. If you use either the fluorescence or the gamma, it should be fine. The blue dye along with the gamma probe seems to be the commonest one usage, but just using the blue dye does seem to be inadequate. We do have evidence from India to say that it does work in our hands. If you do not have any of that technique, because all these are super special. If you look at Sweden, they have only 2 centers which do penile cancer for whole of Sweden. So you do need to have the technology in place. For modified inguinal lymph node dissection, which is more of a surgical approach, wherein what you do is you don't do majority of the things that you do for the radical lymph node dissection. But where it falls is the complication rate is still slightly higher compared to the DSNB, which is 5 to 7%. This is 12 to 35%. And what you do is you make a small incision below the inguinal canal, and you're mainly taking out the 1, 4, and the central one, the Dassler zones. And that should be able to give you majority of the sampling. And if you do have positive nodes, then you go and do a radical inguinal lymph node dissection. Complication rate, it seems to be lower compared to the radical inguinal lymph node dissection. So summary is there in this slide. Any non-palpable inguinal lymph nodes for low risk group, which are TIS, TA, T1A, low grade, you can do surveillance. Anything that is intermediate and high risk, you do a cross-sectional imaging to rule out metastasis, and you have 2 options: modified inguinal lymph node dissection or dynamic sentinel lymph node biopsy. Thank you very much.
Thank you, Sanjay. That was a nice presentation, very clear and crisp. There are no questions in the chat box, which the QA link. Hence, we'll go ahead. Next speaker is Dr. Rakesh Sharma. He is the uro-oncologist at Indo-American Basar Takam Center, Hyderabad, and he is speaking on management of CN plus groins in the penile. Over to Rakesh.
Good evening to all. Thank you, Bakshi sir, for the introduction, and Sogo for giving me this opportunity. And I thank the 2 directors, Dr. Vedang Murthy and Dr. Kanish Bakshi, for this opportunity. My topic for today is management of CN plus groins in carcinoma penis. So to start off, lymph node involvement, as we all know, is the single greatest prognostic factor for the overall cancer survival in carcinoma penis. And previously there used to be a lot of discussion on the role of antibiotics, but now the older series used to say that 30% of the cases will harbor infection. So give antibiotic for 4 to 6 weeks and then do a treatment accordingly. But now the recent series have proven that metastatic involvement can be there in these palpable nodes up to 70%. So better to plan your treatment accordingly. So how do you plan your treatment? So ultrasound guided FNAC is one of the very good indicators Sanjay has already highlighted. But this is one of the articles published in BJUI in 2006, where 16 men with around 25 palpable inguinal lymph nodes were FNA'd, and what they found was and compared with the final surgical inguinal lymph node specimen, what they found was the sensitivity specificity was much higher compared to the clinically N0 groins. It was in the early 90s range, so that's quite acceptable. In a better center, where the ultrasound guided FNAC is done at regular basis, you can further have a better sensitivity specificity. Coming on to the other diagnostic modality which is more commonly used, that is the FDG PET-CT. The sensitivity specificity for clinical N0 continues to remain low, around 50%, 50 to 60 in the sensitivity, and specificity is around 80 to 90. But for the clinically N0, clinically N plus groins, we have good sensitivity specificity beyond 90%. So it is quite a reliable investigation in clinically N plus groin. Even the EU guidelines also mention use of a pelvic CT or a PET-CT with a strong indication. So this is how a patient, when he presents, this should be the flow chart for managing such a patient with a clinically N plus groin. You do FNA and plan accordingly. If it is negative, do a superficial or a modified lymph node dissection. Send for frozen section. If it is negative, you can stop here and keep the patient on surveillance. But if it is a positive, you need to go for a radical inguinal lymph node dissection. Similarly, the FNAC is positive. Straight away, you can do a radical inguinal lymph node dissection, send it for frozen section. If there are more than 2 positive lymph nodes or there is external extension in the frozen, you can plan for a pelvic lymph node dissection and further treatment accordingly. In clinically N plus, if it is CN2 bar N3, generally FNAC is not required. You can visually identify, but still get a FNAC similar pathway. If it is negative, go for superficial or modified inguinal lymphodissection and accordingly plan the further management. If it is positive, these big lymph nodes, better to go for NSCT, which we'll be discussing in the further slides. So this will be the radical inguinal lymph node dissection. This is the incision 1.5 to 2 centimeters below the inguinal skin crease, transverse incision, and another incision is the Lasius incision. If you're planning for transverse incision, you have to take for the, if you're planning for a pelvic lymph node dissection, it's better to go for a midline infraumbilical incision, extraperitoneal, you can go. And boundaries would be the medial border of the sartorius, the lateral border of the adductor longus, and superiorly up to about 2 centimeters of the inguinal ligament. And this will be the area where you will be dissecting. As Sanjay has already mentioned, these procedures, they carry a lot of morbidity. So for modified, it's a little lesser, but when you go for a radical inguinal lymph node dissection, it is in the range of around 20 to 50%. And the major problems what we face will be the skin necrosis and the lymphedema and the lymphocyte formation. So various published articles have shown in the range of around 20 to 50%. Coming on to pelvic lymphadenectomy, the indications, as I've already mentioned, 2 or more inguinal lymph node on frozen section. When you do a radical inguinal lymph dissection on each side, ipsilateral side, you have to do your pelvic lymph node dissection. And extracapsular lymph node dissection, if it is present, you have to complete your pelvic lymphadenectomy. The 5-year cancer specific survival in this patient drops down significantly to the range of almost up to 30%. So from where all these guidelines have come, so this article was published from the Netherlands group in 2015, where they perform prophylactic inguinal pelvic lymph node dissection in patients with palpable positive inguinal lymph node dissection. And what they identified was extranodal extension in the inguinal lymph nodes, or 2 or more positive lymph nodes were predictive of a positive pelvic lymph nodes. And the 5-year cancer-specific survival in these cases was around 17%. A meta-analysis published in BMC Cancer Journal 2015 from the Chinese group, where they studied multiple published articles. Here also they found the 5-year survival rate to be in the range of around 9 to 40%. So coming on to the fixed palpable inguinal lymph nodes, this is already categorized in the NCCN group or the TNM staging as stage 4, because N3 they are stage 4. And fixed lymph nodes, how are they defined? They are basically diagnosed by physical examination and inability to move the nodes or separate nodes from the underlying tissue. The 5-year survival definitely is very low, 0 to 17%. So to image these patients, is better to go get a FDG PET CT scan and ultrasound guided FNAC to prove the malignancy and treat them accordingly. Ideally, NSCT will be required to downstage these lymph nodes, and if there is any micrometastatic systemic disease, will be taken care. And if the patient responds, you can plan for a complete surgical treatment, a radical inguinal lymph node dissection, and a pelvic lymphadenectomy on the same side. Cisplatin-based chemotherapy is generally what majority would prefer, and 4 cycles TIP. After that, a response assessment scan should be done. So, an article published in 2007, where NSCT was given for around 12 patients. 19 to 20 patients, and what they identified, 12 patients had some tumor response, and the overall 5-year survival in these patients was around 32%. And in the non-responder group, the survival was very low, that was up to 9 months only. So these are many articles which have been published in last many years on neoadjuvant for carcinoma penis. And what they identified, the overall response rate is around 50 to 60%. And the pathological CR, what we achieve is only in the range of 15 to 20%. So responders are the one who should be taken up for surgery. The non-responders should be considered for either best supportive care, or you can consider to continue chemo or chemoradiation. So these are the few trials which are in the pipeline. The French trial, where they are prospectively including patients with 4 cycles of TIP in mobile palpable inguinal lymph node, and we are expecting the results in few years. Another trial is the IMPACT trial. Here they have the 4 cycles of NSCT or to concurrent neoadjuvant chemoradiotherapy with cisplatin followed by standard surgery. So these are the patients, how they present with fungating nodes, pus discharge, all those things will be there. So you have to plan them accordingly. You need the help of your reconstructive surgeon. Musculocutaneous flap reconstructions will be required in such patients. Once they have undergone surgery, you have to plan further management in the form of adjuvant chemotherapy. So the high risk features for delivering chemotherapy in this group of patients, positive pelvic lymph node, extranodal extension, and bilateral inguinal lymph node extension are the high risk features. And there are multiple published articles on adjuvant trials with not many patients. One of these were 141 patients. Most of them have very low number of included patients. And the median overall survival in patients who had received adjuvant chemotherapy was 21.7 months, and patients who did not receive was around 10.1 months. Coming on to adjuvant radiotherapy, this is a systemic analysis which was performed by the European Association Group, collaborative group for the EU guidelines, and they included multiple studies published from 1994 to 2016. What they concluded by saying is, as of now, there are no better evidence to give adjuvant inguinal radiotherapy in node positive patients. So as of now, it is not recommended. But a recently published accepted article to be published by the Vedang et al. Group, where they have recommended and clinically validated the inguinal clinical target volume in these patients, where 33 patients were identified with around 222 inguinal lymph nodes. First, they identified by the prior CT scans done for this patient where are the lymph nodes located. So majority of the lymph nodes, 99% were located anterior to the femoral vessels. And accordingly, prospectively, they planned the treatment, and IMRT technique was utilized. So what they found was at the end of 24 months, none of the patient developed local recurrences, and the grade of complications, that is a grade 1 and grade 2 lymphedema, were also quite low. So what does the EU guidelines say? In the fixed inguinal lymph node, you consider for neoadjuvant chemotherapy.
Rakesh, a little faster.
Just last two slides, sir. And adjuvant chemotherapy in these patients, strong here weak recommendation and strong recommendation. Radiation therapy, as of now, not recommended. But when you come to NCCN guidelines, it can be considered, has been mentioned. Follow-up, 3 months to 6 month follow-up has to be considered. The regular examination, ultrasound. If you have suspicious node, get a FNAC and imaging done. Thank you for the opportunity.
Yeah. Thank you, Rakesh. I think we're slightly delayed, so we go to the panel discussion. As Gagan, I invite Dr. Gagan Prakash, my colleague at TMH, to come as the moderator. And as Gagan puts up his slides, I invite Dr. Jagdish Kulkarni sir, who will be the chairperson and be giving his final comments on this. I also would like to invite the panelists, Dr. Vedang Murthy, who is already the program director here, Dr. Santosh Menon, uro-oncopathologist at Tata Memorial Hospital, Dr. Bhalchandra Kashyapi sir and Dr. H.B. Tongaonkar sir, who are both surgeons, uro-oncologists, Dr. Vineet Talwar and Dr. Amit Joshi, both uro-oncology doing medical oncologists, and Dr. Satishan, who is a surgeon. He is also the director at RCC Malabar. Welcome everybody. Gagan, it's to you.
Thank you, sir. Thank you, Dr. Rahul, Dr. Bakshi, and Dr. Vedang for giving me this opportunity. I hope I'm audible.
Yeah,
Yes.
Yeah, and also thank you for making this opportunity even bigger by selecting such a star-studded panel for this discussion. The introduction has been given by Dr. Bakshi. So before we dive into our case scenario, let me take you to this publication, which was done almost 2 decades back. Dr. Kulkarni is here, Dr. Tongaonkar is here. This was published in the Journal of Surgical Oncology, and to my mind is one of the strong and prominent papers from India with 150 penile cancer patients from a single institute. I would like to start by asking Dr. Tongaonkar, sir, what have you seen, or have you seen any change in the penile cancer presentations in India over the last 2 decades with your vast experience? Tongaonkar, sir?
Maybe you can ask Dr. Kulkarni sir.
Yeah. Dr. Kulkarni?
Well, of course, the article clearly says. Then we used to see something like 250 new cases every year. I do not know what is the current thing. And most of the patients were T3 and with the fungating nodes, about 40 to 50% patients. But we started getting, as we came around 90s, and we started getting some of the early cases and non-palpable. So we ran a study of in 94, which is published in European Urology. So there is definitely downstaging of the number of cases, as also downgrading of the tumors. And I'm sure in now practice for last 20 years, I'm also seeing very limited number of cases. But what is important is I am seeing the patients in octogenarians and nonagerians. So I think the age change occurred there now, which in private practice I'm seeing patients with above 75, 80, almost 90 also. 2 patients I saw recently of 90 years. So that's the thing. Remaining things again remains a still problem.
Right. Thank you, sir. So let's see our scenario. This was a 61-year-old businessman, hypertensive smoker, who presented with a penile growth that he had for more than a year, but was taking alternative medicine. The pictures are quite clear. You can see that there is a lesion, ulceroproliferative growth over there. There was some individuation proximal to it. And on examination, on one side, on the right side, there was a single node which was palpable. We headed for the biopsy of the penile growth, and I would like to ask Dr. Menon, sir, when we look at the biopsy and when we look at the pathology, what is it that you find difficult in reporting on the biopsy, particularly in relation to the grade, or say if there is a variant histology and HPV? Can all this information be gathered on the biopsy?
Sorry, Gagan, my video is not working, and thank you for having me on this panel. So your question is basically, is there a difference between a grade in the biopsy and a grade on the resection of variant or HPV? So what I understand is if you have a very clear-cut superficial cauliflower-like growth and you palpate that it's not a deeply invasive, most of the times it, sorry, yeah, I think my video went still not starting. So forget it. So the problem is on a small biopsy, the grade we may call it G1, but on the final histopathology that may be upgrading to the tune of 25 to 30% in several cases. So that's an important clinical decision, if I'm not mistaken, Gagan, because yes, grade would determine your inguinal node dissection hall. So that's a very important problem which we encounter. In a small biopsy, we may not be very accurate with the grading. Whereas coming to HPV, I think P16 gives us a good acts as a good surrogate marker. And whether it's a resection or a biopsy, most of the times P16, if it's a block positive, we can tell you the HPV status as a surrogate marker on a biopsy. Coming to variant histologies, many variant histologies like lymphopithelioma-like and medullary, they are all usually on the invasive front and mostly seen in the deeper tissues. So that's the difference between a biopsy and a resection grade which we find.
Right. So further, as we were evaluating this patient, we wanted to image him. We've had an excellent talk on imaging, but Dr. Kashyapi, so this patient needs a metastatic workup also, because one side there's a positive node and on the other side there's an N0 groin. Yeah. So what imaging, either one imaging or a combination of these images, would you want to do for this patient?
I would do an FDG PET CT in this patient, which would give me evaluation of both the groins as well as the pelvic side, pelvic node.
Okay, and for the N0 side, if the
same FDG PET CT will look at that side also.
Right, but you wouldn't want to have an additional sonography for the groin. If the FDG is fine, you are okay with it?
I'm fine with FDG, because your clinical examination showing a palpable node on one side, the other side is not palpable. So clinically yes, N0. This right, FDG PET CT will answer all questions on both the sides. Okay. No need of a separate ultrasound.
Right. Dr. Satisan, so the site which has the positive, as in a clinically palpable node, most of the times you'll be okay to take your surgical decision based on that, or would you still FNAC and then take a call?
Thanks, Gagan. And actually, clinically, I would take an FNAC. I have a reason for that. Though the FNAC has got a false negative rate, it's quite high. It amounts from 7 to 30% in various literatures. But still, it might, if it is positive, because the specificity is quite high, So if it is positive, I can explain to my patient regarding the procedure what I'm planning to do, and I can straight away go for the the conventional nodal dissection. But at the same time, generally, if you look at the literature, the people say that the FNAC may be a resort for those cases if a node is found in low risk cases. But anyway, in clinical practices, we go with FNAC because it's easier procedure, and within 1 or 2 days, we get the result also.
Right, sir. And do you still see such cases in practice, sir, where there is a node which is not malignant but maybe reactive or infective or some other reasons?
Yes, sure. Yeah, we do see that. We do see now, please. Actually, the number of penile cases in Kerala has come down significantly. Yeah.
So we did a PET CT for this patient, and we actually found one single node which was really avid and prominent, as you can see. Nothing much on the left groin and nothing on the pelvis actually, and there was no distant disease. There were no retroperitoneal nodes. So essentially, we could, based on the clinical findings and the radiological findings, we said that this looks like a T2 node positive M0 squamous cell carcinoma of the penis. Now, the partial penectomy was planned for this patient. Let's focus on the groin management. So we have one side a no positive disease and the other side a clinically N0 groin. And, this is the options that we have as of today. And for the node positive groin, we could either do a complete groin node dissection depending on the frozen section, or irrespective of the number of nodes, we could go ahead and do the complete groin node dissection at one go. We could do a laparoscopic or robotic veil for the positive side, or we could do an open groin and a laparoscopic pelvic dissection. Whereas for the N0 side, generally when you do an open surgery, it could be one of the templates, either modified inguinal or a superficial inguinal lymph node dissection, dynamic sentinel lymph node biopsy, more common in some centers, or a robotic also for the N0. So surgical plan, I would like to take opinions from both Dr. Kashyapi as well as Dr. Satheesan about what would be your choice of addressing these two sides.
Again, my choice for him would be an open, complete ilioinguinal lymph node dissection, and I would err on doing it on the opposite side also. So 2 groin incisions and 1 midline extraperitoneal for both pelvic. This patient has been on some alternative therapy for 1 year.
Right, sir.
I am not very confident that he will remain on a regular follow-up, and so this might be my only chance to help him get cured, perhaps. So, and the morbidity of a non-palpable groin node on the left side may not be as much as it is feared. So, my suggestion for him would be a bilateral ilioinguinal node.
So, if this node, which was a single one on the PET, turns out to be a single node on the frozen also, would you still want to address the pelvis, or?
I would still address the pelvis.
Right. Dr. Satheesan, what would be your take on the surgical options for both the sides?
Yeah, I would go for an open complete inguinal nodal dissection on the N1 side, and go for a modified dissection and frozen section on the opposite side. Can you hear me? Yeah. Can you hear me?
Yes, sir. We can hear you. Yes.
Yeah. And if the node is positive, and if more than 2 nodes are positive on that side, I would do an iliac dissection on the same instance, because I usually put a lasius incision. In iliac dissection, pelvic dissection, I'll do it on the same side as the N1 plus side. And if the number of nodes is more, and if it is the extracapsular extension, or if that's also if found on frozen section, I'll go for the iliac dissection. And if it is more than 4 nodes or something, if my pathology says more than 4 nodes are there, then I think I'm in a dilemma whether we should do an iliac dissection on the opposite side. That's what, because generally we don't have the habit of doing the iliac dissection on the other side. So this is still an area of concern and a little bit of controversy. Yeah.
Has Tungaonkar sir joined in for panel?
I think he joined in. He's there.
Huh?
I think he's there.
He's there, Gagan.
Gagan, just a question. Santosh. Hi, Gagan. Santosh here.
Yeah.
Yes, Santosh, go ahead.
Just for the sake of how many times have you seen frozen section with 4 nodes positive or 3 nodes positive? You don't usually get couple of nodes positive in on frozen section. I don't remember seeing 4 or 5 nodes positive on a nodal dissection at frozen section.
Yeah, so I think what generally happens is that the moment we get 1 or 2 nodes which are positive on the frozen section, we go ahead with the complete. We wouldn't send that for frozen, even if we are seeing those.
Exactly.
Sir is there. Yeah. Sir, can you hear us?
Yes, I can hear you.
Yes, sir. So could you see the earlier slides on the case scenario? Or?
No, I could not log in before. I just logged in because there was a lot of difficulty in logging in. Hello?
Yeah. So I'll just quickly take you to the scenario. So we have a patient with a penile ulceroproliferative growth and one-sided palpable node, which was also avid on the PET scan.
Yeah.
And we were discussing about how to address the positive side with one-sided node and how to address the clinically N0 side. And we've got 2 slightly different management options. Dr. Kashyapi would want to go ahead and do a complete inguinal lymph node dissection on the positive side as well as on the N0 side. And Dr. Satisan would want to, the N0 side, he would want to go ahead based on the frozen section on that side. But he would want to start with the modified inguinal lymph node dissection.
Yeah. I think what I would do is definitely there's no problem about the positive side. You have to do a complete inguinopelvic lymph node dissection. But about the other side, how many just nodes are positive? Just one big node? What is the size?
Yeah, so it is just one big node around 2 centimeters.
Yeah. But other side definitely needs to be addressed, and I would rather in this situation go ahead for a modified lymph node dissection and do a frozen section. If it's positive, then do a complete lymph node dissection.
Okay, sir. And actually, I think we have other people. I think Rakesh might want to do a sentinel node biopsy on this side, and maybe Rahul sir would also want to consider a robotic veil for both the sides in a non-bulky node situation. These options are there, and this was very recently from Europe actually, where a collaborative study, multiple centers, 35 surgeons, and what they found was that whether it was dynamic sentinel lymph node biopsy, which is done largely in almost more than 80% of the centers in Europe, or whether it is inguinal lymph node dissection, there are quite a few areas where there is no consensus. So this particular survey was to see about the consensus, and even basic things about the boundaries, about the templates are things where there is a lack of consensus. So we are possibly not the only ones where there is a lack of consensus. But I think with the kind of numbers of penile cancer that we see, we can potentially create a consensus over here. Tungonka sir, I would want to ask you that in this particular patient where we already have a node positive on one side, would you want to not consider smaller templates or DSNB, because probably the chances of having a node positive on the clinically N0 side in this patient is going to be more? I mean, should we be more radical here?
Yeah, no, I would definitely consider modified lymph node dissection and not a DSNB, because in my opinion, the false negative rate of modified lymph node dissection is much lesser than that of DSNB. So at least in my practice. So I would do a modified lymph node dissection with fossa ovalis, and then if that is positive, and of course the chances of this being positive are definitely higher in view of the other node being positive, but I would still go ahead with the modified template first and then do a complete lymph node dissection if necessary.
Okay. Dr. Santosh, so we are basing a lot of our decision based on the frozen section over here, whether to address that groin completely or no. So how many times does it so happen that the frozen section is negative, but when the final tissue comes in the histopathology, it turns out to be positive? So I mean, the false negatives of a frozen section.
Yeah, so Gagan, this is a difficult question. Although for a strange reason, I can tell you, compared to other squamous cell carcinoma, say head and neck and all, for a penile case, the chances of node being negative is as high as 20 to 25%. So in our recent thesis study, we have compared this and we have found out that about 20-25% chances of negativity may be there. Although we do try to sample all the large nodes, sometimes the smaller nodes are not sampled at frozen. That would be one of the causes of being a false negative. And sometimes even the larger node on deeper sectioning on final histopathology turn to have a small metastasis on final section. So these are the reasons which we have seen that false negativity.
Dr. Kashyapi, based on all this, do you think it would be wise to say that if frozen section facilities are not available, which might be happening in a few centers which are doing penile cancer surgery, then one should not address the groins?
I would not agree with this statement. If you don't have a frozen section, I would err on the side of overdoing the thing rather than underdoing it.
Okay. So this patient underwent a partial penectomy and one-sided complete groin node dissection. On the other side, it was the superficial inguinal lymph node dissection, slightly bigger template. The histopathology of the primary was this, with a basaloid variant of squamous cell carcinoma involving the spongiosum. So technically it was a T2 and LVI and PNI. Now, Dr. Menon, how would you rate this disease biology? I mean, based on the T stage and the other findings, particularly with the new changes which have happened in the AJCC and your work which has been going around it.
Yeah, so Gagan, basically, again, according to AJCC, the corpora spongiosum involvement is T2 and cavernosa is T3. So that was based on a study in MD Anderson, and that's what they have been proposing. Coming to basaloid variant, basically the basaloid variant is a HPV positive, but these are very aggressive variants. So these is, even if it's HPV positive, this throws metastasis. You can see that LVI PNI positive. They can creep along the nerves, and the margins can be positive in these cases. So that's very important about the variant histology. The other thing is, in our study, we have seen that removing the urethra from the AJCC7 had was probably premature in some aspects. Although AJCC8 does do better when you have DFS and OS in comparison.
Right, but the point over here is that this patient, the LVI and PNI should be given more importance than the fact that this is T2 on the AJCC.
Yes, so even in T1 staging, the current AJCC takes that LVI into consideration. PNI has already been there. So I think in T2, T3 also they need to start considering LVI and PNI as being part of somewhere part of the staging. So that might be the changes which are expected.
Now the histopathology of the nodes on the left side, which was N0, there were 9 nodes dissected. On the right side, from the groin, there were 3 nodes dissected, and one of them was positive with extranodal extension. The pelvis had 10 nodes dissected, and they were all negative. Because of the extranodal extension, this became a N3 disease. And I would want to ask the surgeons, Dr. Kashyapi or Dr. Satishan, any comments on the lymph node yield? Any cutoff values that you would use in practice to say that this has been an adequate dissection?
Not really. This seems to be an adequate dissection. Only thing I'm a little surprised, there was only a single node on the right. Only 3 nodes. So there would have been perhaps more nodes on the right.
Right. So this it actually looks inadequate, and there've been studies where they've tried to look at the cutoffs which can say or which can predict the survival, and the lymph node yield cutoff has been proposed as 15 nodes and for the groin and around 9 nodes for the pelvis, and these numbers are predictors for recurrence-free survival and overall survival. And there have been actually nomograms also predicted, nomograms also constructed looking at the lymph node yield as well as lymph node density with values of 13 and 9.3%.
So Gagan, this is for both right and left together, 15?
No, this is for one side.
Each side 15.
Yeah. So I would anyways check it, but I think it is each side. Now this patient, the usual scenario after groin node dissection, the drains kept on slowly creeping up. Around day 12, one side the drain suddenly dropped down to 20-30, and we know what has happened. On the other side, it was still creeping up. So the side which it had come down was because there was a small wound dehiscence, and the drain wasn't really pouring, the lymph was coming out from the wound. Dr. Kashyapi, some practical tips on prolonged drain. Sometimes these just keep on coming for weeks together. And also in a scenario where sometimes the drain comes out and you have a messy situation.
Keep patience. That is the only scenario. And prepare the patient prior to surgery only. You are going to have a lymph node drainage, the draining up for a quite long time.
Do you kind of inject things, or do you use something during the surgery to kind of reduce the lymphoria?
I would try to ligate everything rather than using a cautery. As far as especially the lymphatic coming from the leg, I would, as far as possible, ligate most of the things rather than using a cautery. I don't inject anything, or I don't use anything like sclerosing agent. No.
Okay. Dr. Satisan, this is a common scenario, and often these patients with node positive are waiting for their adjuvant therapy. Now, if somebody has a prolonged drain, do you wait for the drains to come out before starting radiation or before starting chemo, or either of these? What's your usual practice?
My usual practice, we wait. We wait because with the drain in situ and the lymphoria, generally we are not very keen to start chemotherapy or radiotherapy. Radiotherapy generally we don't use. So chemotherapy or medical oncologists are also elected to start. Simple reason is that if the possibility of infection, and it might the entire thing might create problem. So we generally wait. We generally wait for it.
Is there somebody who would believe that if the wound is intact but the drain is high, we can still start radiotherapy because that might take care of the drain and reduce it?
No.
Okay. And generally, if you have to wait, then what is the window till you wait? I mean, what is the window that you think that you should start adjuvant if that has been planned? Is it like 6 weeks or?
Ideally within 6 weeks, but we extend up to 8 weeks. So beyond 12 weeks, I think that the benefit is almost negated. So we generally wait up to 6 weeks. So 4 to 6 weeks is the ideal time to start the adjuvant treatment.
Gagan, the question you asked for radiotherapy to reduce the discharge, I think we do it for salivary glands, not for this region. Okay.
Okay. So I mean that's a theoretical concept, and I was wondering if it works. Possibly doesn't. So the next I would like to ask Tongaonkar sir. Sir, when in practice patients who got a complete groin node dissection and are likely to get adjuvant, say radiotherapy, how do you measure lymphedema, and particularly on follow-ups? Do you use some objective tools or to keep a track of lymphedema?
Yes, I have got a very good occupational therapist who looks after the lymphedema patients, and with the calipers, she is able to measure the lymphedema. I don't know how accurately, but if you use the same method, she uses it at 3 different levels, and that is, I think, one is the mid thigh, the second is the knee, and one is at the ankle. So these 3 places, and you have what shall I say, a monitoring of the edema, whether it's reducing, whether it's increasing. So that's fairly accurate, I would say.
And
but
sir,
as far as the management is concerned, yeah.
Yes. So do you start the compression only if there is an increase in the girth?
Yes. I mean, compression stockings I give from day 1 post-operatively. But the thing is, whether they require any lymphopress or anything, that depends on whether the edema is still pitting or not, one. And secondly, whether there's any increase. Thirdly, whether the patient is, it interferes with his normal activities. So these are the 3 parameters by which we decide whether to use lymphopress or just continue with compression stockings.
Right, sir. So this patient now with a pathologically N3 single node, we have these options. So, if we are considering adjuvant chemotherapy, then we have options of 2 drugs or 3 drugs. if you're considering radiotherapy, then it could be alone or with chemotherapy, or chemotherapy followed by CTRT, or considering that this is only one node, is observation also an option? So I would like to first take the surgeon's opinion. Kashyapi sir, what would be your choice of adjuvant therapy in this patient, if at all?
He has an extranodal extension. My choice would be a chemotherapy.
Chemotherapy only?
Yes.
Tungaonkar sir, would you agree with that, or would you want to add radiotherapy as well?
Well, first of all, there are no trials by which you can say that this is better than the other. But here, because there is external extension, probably I would add local radiation therapy to the treatment along with chemotherapy.
Right. Dr. Satheesan, what would be your choice between the options?
So, adjuvant chemotherapy, and this will be my choice.
Right, sir. So, Dr. Vedang, you have 3 back-to-back questions coming up for you. So, we've always shuddered from groin node dissection followed by radiotherapy, giving a bad lymphedema for the patient, toxicity. Over the years, over the decades, do we have a better understanding how to deliver this adjuvant radiotherapy? That's the first question. The second is that when you do decide to give radiotherapy, based on the pathology, how is it between an N1, N2, N3, and if an N3 between one with extranodal or pelvic? And the third thing is, in this whole decision, does HPV status come into play anywhere?
There's some disturbance. Tungaonkar sir, I think if you can mute your mic, that will be good, sir. So thanks, Gagan. Do we have a better understanding how to deliver? Yes. In every other site, we have been talking for decades now about IMRT and IGRT and stuff. Whether that applies to groin is something that we need to see yet. We have to produce the evidence because EAU, EUA, AUA, NCCN, they are all tethering on the borderline still of not clearly saying that adjuvant radiotherapy should be given, except NCCN. So the first is, how do we do IMRT in the groin? That is the first question. There is no literature on that, except very recently we have just done some work. One of my students' thesis was to look at the distribution of groin nodes, about 220 groin nodes, how they are distributed around the femoral vessels exclusively in penile cancer, and how do we use this information to actually suggest or recommend guidelines to contour the nodes for IMRT. You all know we need to delineate what we want to treat with IMRT and what we want to spare. So there is, up till now, there is no information on that in the world literature. So this is very recently come out, which we have validated also. So clearly there is a way to do it now, a standardized way, and IMPACT is looking at radiotherapy in a big way, and I think it is struggling to recruit also the big trial. My view is that if you go back, Gagan, to your questions, should we be doing radiotherapy? I think given that this patient has ENE, the best evidence till date is for radiotherapy is ENE, and we are again on the verge of publishing a largish data set. Probably it will be the largest one when it gets published, hopefully in the next month or so, of about 128 patients who over the last several years at Tata Hospital, some were observed, so there no adjuvant therapy was given. We have a large median follow-up of nearly 50 months. Some were treated with a single modality, some had adjuvant radiotherapy only or adjuvant chemotherapy only. Some had a multimodality treatment of combining chemoradiation or chemotherapy followed by radiotherapy. Essentially, all comers, all sorts of things that happened in the JC depending on who was present, what was happening. So not really evidence-based, but practice-based. So when we looked at this, one major thing came out. If you see on the right, the prognosis, and all these were N3, remember, either they had PNE or they had pelvic node positive. If you don't do anything, the prognosis is extremely poor. Hardly there are 10%, 15% people who are alive at 2 years. But if you do something, so some adjuvant therapy, the overall survival increases dramatically. And this is a point I wanted to make when you're talking about the leakage. Whether to keep observing, and if there is discharge or drain for a very long time, do you keep observing or you go ahead and give some treatment? I think that's a very important call to take, and I would rather push ahead and give some treatment because the prognosis is quite bad in these patients if you don't do anything. Now, what we also found was the more intensive the treatment, and especially adjuvant chemo followed by CTRT, although this is a retrospective, although these are small numbers, but this will still be probably the most appropriate evidence yet, that they did the best. The more aggressive, it was the best. And you can see the 3 or 4 curves in middle, they were all the same. You give radiotherapy alone, chemotherapy alone, CTRT on its own, it was not making they were all more or less the same. So some indicator that you've got to give something, and more aggressive is better, is my view. Now, regarding the third question about HPV, I think it is going to make a big difference in the coming years. There was a very recent article in, I think, European Urology Oncology, where they looked at a large database in Europe and found a large and significant overall survival benefit in patients who are HPV positive, regardless of their end stage. When they received post-op RT, adjuvant RT, there was an overall survival difference in the HPV positive patients. So we've started doing HPV in all our patients, but we have not brought that into practice yet. But I think it is going to make a big difference like it has done in head and neck cancers. I'll stop there.
Thank you, Dr. Vedant. Yeah. So finally, questions for our medical oncologists, Dr. Vineet Talwar and Dr. Amit Joshi. Sorry to keep you waiting for long, but what is your preference for neoadjuvant and adjuvant both? What kind of regimens do you prefer? Either of you could take this question.
Well, if I were to add, the sheet anchors is basically platinums, and amongst them cisplatin is the preferred drug of choice. And here again, sometimes you find that the general condition and performance status of the patient is poor. In that case, you might use doublets, that is a combination of taxanes and platinum, especially paclitaxel. In some studies, docetaxel has also been used, but I would personally prefer paclitaxel plus cisplatin. But given a choice, if everything is fine, the general condition, performance status, everything is good, then I would use a triplet, which would be paclitaxel, ifosfamide, and cisplatin. And this would be given Q3 weekly. Give it for about 3 to 4 courses, and then after that, reassess. The other combination which was there earlier, it used to be cisplatin and 5FU, but generally nowadays in most of my patients I'm using platinum with a doublet of a taxane, or if everything is fine, then a TIP protocol, that is Taxol, ifosfamide and platinum.
Dr. Amit Joshi, while most literature is talking about PIP, but what are your practical problems? Are we able to give this to our patients, particularly the patients that we see at Tata?
Yeah, I think what Dr. Vineet has said, in patients who is otherwise fit. So if a patient is, because the toxicity of a triplet is going to be more than the doublet, that is sure. So and the logistic problem, and unfortunately most of the patients, they are from a poor socioeconomic strata that what we have seen. And so the logistically, monetary wise, that is going to the real problem. If given a choice, patient is fit, monetary well supported, then there is no doubt that triplet is better than the doublet. And I think gradually all the guidelines are gradually shifting from the 2-drug to 3-drug and giving. If you can't deliver the 3-drug regime, then definitely taxane is better than the 5-year because the associated issues of infusion for 24 hours, prolonged mucositis, neutropenia. So if patient is fit, triplet chemotherapy. If not fit for triplet or logistic problem, then a doublet, probably with taxane based, is the current practice that we do in our hospital.
So has the immunotherapy thing touched penile cancer so far? And I mean, is there any data so far or trials going on, I believe? Dr. Vineet, you would want to
talk of immunotherapy in CA-penis, as such, the data is very sparse. And there is a paucity of data. But then if you take a corollary from the trial of pembrolizumab, in which you have the agnostic marker, which is the microsatellite instability. If MSI is high, then probably these are the patients who would benefit from immunotherapy. Having said that, even if the patient has MSI high, I won't be using it as first line, and I would be giving preference to the chemotherapy drugs first line and probably use it in the second line. And thirdly, I would like to add that my experience, which has been in patients who are non-CA lung cancer patients and who have microsatellite instability, in these patients, the drug does not work as good as it would do in a CA lung or a CA colon patients for reasons not known. It is probably the organ-specific effect.
Right.
But yes, if you have this marker, then you can use in these patients.
Right, sir. So yeah, the same things in a summary. Both NCCN and EUA guidelines say that it should be 3 drugs if that's possible. And radiotherapy, EAU doesn't recommend that, but NCCN does recommend where it is considered appropriate. And we know about the impact which should possibly, whenever it is, it comes to a point where we get some results out of it, it should address a lot of these queries, particularly for the residents, know about this trial and also a very interesting trial design. So you should read about it. I had this small rapid fire thing about small penile lesions, but I think we'll skip it because of the time. And it has been very well covered in the prior talks about penile preservation. So I would like to just end it with, saying that what I learned while creating this panel was that I think there are huge opportunities which we have in India, with SOGO or USI, where, we are the country where probably DSNB, MILD, SILD, robotic, everything is being done, and we have good numbers of penile cancer. And I think that is something which can be compared. If at all it has to be compared in one country, then that would be in India. Indian franchisee of impact or something similar is, something should be looked at. And QL tools or lymphedema tools for Indian patients is again something which we should be considered looking at the numbers of penile cancers that we see over here. Thank you so much, all the panelists and organizers.
Thank you everybody on this panel. I would like to invite Dr. Jagdish Kulkarni for his final comments, and then Dr. Raghunath.
Well, good evening to you. I'm very impressed with all the discussion, and practically it covered all the points. And I must say that there are many takeaways for me, even in spite of so much of years of penile cancer treatment. Of interest to me was the imaging techniques in primary, both as well as to know the involvement of the corpora and nodes, of course. Having said that, the buzzword should be that the organ preservation should be not only limited to young age, because we are seeing patients over 75 and they ask us, doctor, can you save the organ? So I think for that age limit should be removed, and I think that will be happening to all of you, that they will ask, even I'm 75, it doesn't matter, but I would like to have that preserved, number one. Coming to the node, I was impressed to see that in C0, and I note there that 25% micrometastasis, it's almost 1 in 4, which impresses me that there is nothing like CN0 at all, because I do not know who is that 25% or who is that 75% who is negative. So that is the point which we need to be. And of course, we talked about once N becomes positive, you got a trimodality treatment. That is what Vedant clearly said that. My only concern to all these things are, yes, of course, we are progressing in terms of improved survival, everything. But the quality of life and the morbidity of the groin dissection, be it plus additional 2 local treatments like surgery and radiotherapy, how does that go far along? And if it happens, say for instance, age of 50 years, certainly he's got 20 years to go. It's 70 years, 80 years, and these things. So we will have to develop these kind of further guidelines in terms of age-related morbidities as well, because we've seen patient with groin dissection, come what may, whatever you do, there is always a morbidity. And I think that is, we're talking about this MIS, and I was impressed to see that robotic things have come up now in a big way. Well, of course, it may not be available to practically everybody, but I'm sure that should be the way. With multiple platforms coming up, it should be available there. And as Gagan finally summed up, that we have to develop our own guidelines perhaps, and time has come. I used to meet Horenblas in Amsterdam in 90s. He was there and he said, you all guys have to produce your own guidelines. And I think this SOGO will do that in future. With this, I think I close my comment. Thank you very much and great discussion.
Thank you, sir.
I think over to Raghunath. Yeah.
Thank you, Ganesh. Very good evening. I would not take more time. They are running behind schedule. It was fantastic and very informative first masterclass from So. We had a couple of webinars, but this is the first masterclass. More than 150 delegates, including faculty, participated in this. And first, I wish to thank the program directors and my close friends, Dr. Ganesh and Dr. Vedang, for planning and curating this program so well. The selection of topics and the speakers was really amazing. And I thank all the speakers. They did a great job and they covered all aspects of, whatever the topic was assigned to them. It was really good. And I thank all the speakers. And coming to the panel discussion by Dr. Gagan, he covered almost all practical aspects and practical scenarios. It was an excellent panel discussion. Thank you, Dr. Gagan. And I thank all the panelists who shared their vast experience. It's very difficult to have great experience with penile cancer. With prostate cancer, with RCC we have, but very difficult to have practical experience with penile cancers. And we had a star-studded panelists. Thank you all. And at the end, Dr. J.N.K. sir's excellent final comments with its more than 40 years of uro-oncology practice with this is really amazing. Overall, it was a great program, and I thank you all, the participants, all the faculty, and particularly the program directors for curating this program so well. We wish to have similar master classes in future to benefit predominantly postgraduates, young urologists, uro-oncologists, radiation and medical oncologists. And we have lined up a couple of programs for future. The next program would be in September 25th. We have a webinar on the role of artificial intelligence and machine learning in uro-oncology. We are going to learn a lot of futuristic things. Dr. Ginil Kumar is the program director for that. He has already planned a lot of activities for this webinar. And in October, we have PG courses in uro-oncology. And November being the prostate cancer awareness month, it's also called November month. We will have prostate cancer master classes. And finally, I thank Fering for their constant and unconditional support extended to SOGO for conducting all these academic activities. So I thank one and all. With this, we have come to end of this program. So next we'll be catching up again next month on 25th. Dr. Ginil Kumar is going to conduct this program on artificial intelligence and machine learning in uro-oncology. It's a very interesting talk. He's going to cover all aspects of uro-oncology, where all we are going to use, probably 5 years, 10 years down the line, what we are going to learn, all these things. With this, I thank one and all. Good night. Thank you.
Thank you.
Thank you. Thank you so much.
Right. Thank you, everybody. Right, sir.
Thank you, everyone.
Thank you.
Thank you, everyone. Thank you.